Good morning, good afternoon, good evening, everybody. Welcome to today's postgraduate course, Ending the TB Pandemic with Innovative and Updated WHO TB Recommendations. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Your microphone has been muted to avoid background noise, and we encourage you to turn your webcam on throughout the session if you're able to, and if your internet connection allows it. Can we also please ask you to change your display name to your name and country? In today's session, you'll have the opportunity to submit text questions and comments to today's presenters by typing your question into the chat. You can send questions via the chat at any time during the session. The moderators will collect them and address them after the speaker's presentation in the allocated Q&A section. You will also have the opportunity to intervene also by submitting a request to do via the chat or by using the hand raise function within Zoom. The moderators will record your request and inform you when you can intervene. They will have the opportunity to provide feedback in the end of the session evaluation survey, which will appear directly in your browser once the meeting closes. Please complete the survey right after the workshop, as the link will only be available for a short period of time. You will receive a certificate based on your attendance and the completion of the evaluation survey. And also, you may be able to claim some CME points as this session is accredited. Please note that this session is being recorded, and recording will be available to the public a few days after the session. Finally, it is my pleasure to inform you that today's chair are Matteo Zignol and Norbert Ndjeka. Over to you, Dr. Zignol and Dr. Ndjeka.
Thank you very much, Caroline Bennett. Thanks to the union for organizing this postgraduate course, and also welcome to everyone for joining to us this afternoon. As mentioned by Caroline, my name is Matteo Zignol. I am a medical epidemiologist. I work for the WHO, and I'm currently heading a unit in the Global TB program that deals with the TB prevention, diagnosis, treatment, and care. And I have the pleasure to co-chair this postgraduate course this afternoon with Dr. Norbert Ndjeka, who will shortly introduce himself.
Yeah, thank you so much, Matteo. Colleagues, I'm Norbert Ndjeka. I serve as the Chief Director, TB Control and Management under the NTP South Africa. I work as an Honorary Associate Professor in University of Cape Town. I also serve as the Chair for RGLC Afro. It's really my pleasure to co-chair with Matteo Zignol and the capable speakers that we have today, very capable individuals that we have that are going to be talking to us today. I know it's morning for some people, to us it's already afternoon. Thank you. I'll hand over to Matteo to take us through the objectives of the course.
You're on mute.
Thank you very much, Norbert. And so this afternoon we have actually quite a long course. It's a total of 3 hours. And the overall aim is to understand and keep up to date with the most recent WHO evidence-based recommendations throughout the spectrum of TB management, including prevention, screening, diagnosis, treatment, care, and of course, special populations, including childhood TB and adolescents TB, as well as TB and comorbidities. So the session is structured into 5 presentations with a total of 7 speakers. As Norbert said, these are all global experts in their own respective areas, which will be, staying with us throughout the course, not only to present the latest in terms of WHO guidance, but also, and most importantly, to answer to your questions. So please write your questions in the chat. Some of them will be answered immediately in writing, and some other questions will be taken on for a discussion towards the end. It's also an opportunity to discuss and understand the aspects, barriers, opportunities for the adoption of those recommendations in countries. I think that's all from me. As I mentioned, the speakers will be introduced when just before they will be called for their presentation. I don't know, I hand it over to Norbert to introduce the first speaker and the first presentation. Thank you, Norbert. Let me check if Norbert is with us. I cannot see him now.
I see him online, but we cannot hear Norbert.
Right. Otherwise, for the sake of time, let me introduce the first speaker, and then I'll give Norbert the floor for the second one. So the first speaker is a colleague, a very dear colleague. His name is Dennis Falson. Dennis comes from Malta and works at the Global TB Program at the WHO for now many years, nearly 15 years, as a medical epidemiologist. And he leads a team that deals with TB prevention and prevention. I hope then you can hear me. There is some noise. Dennis, can you hear me?
Yes, yes, we can hear you. There is something Losef, I think she needs to mute. Okay,
right.
I think she's muted.
So over to you, Dennis, for to start with the first presentation for today, which is titled the WHO Knowledge Sharing Platform, Recommendation Mapping and E-Learning Modules. Over to you, Dennis.
Yeah, thank you very much, Matteo. Can you see my screen?
It's in full screen. Thank you.
Full screen, okay.
Yes,
so
we can see. We can see the screen loud and.
Excellent. Thank you very much. So, so my presentation will focus upon the rapid access to TB guidance. Last year, for those of you who joined the postgraduate course, we had an introductory discussion about this, and I will share a little bit the more recent updates to the knowledge sharing platform and some other associated materials that we are using to communicate better our normative guidance. So first of all, I wanted to start maybe with a poll and just to see how many people, sort of get an idea of how many people who are connected today have some sort of familiarity with this. So you should see a poll on your screen, and kindly ask you maybe to reply to these 2 questions. I see people have started, yes. Okay, we'll keep it a few more seconds. Okay, so yeah, we have over 100, so over half the people connected, I think, have replied, but we need a bit more. Okay. Okay, so let's get to 150 at least. We're at 142. Please keep going. Okay, I think things are plateauing a bit, but yeah. Okay. So there's someone who's asking a question here or raising his hand. Okay. If this is an issue around the poll. Okay. So I think the poll has been ended and we have about 150 participants. So 56% have said that they have visited the knowledge sharing platform. Okay, so good. So so quite a few, majority, but 44% did not. And those who have visited the platform, they went to the website mostly, 63% from what I'm seeing. Yeah, and some 17% over the mobile desktop app and 20% both. Okay, so fair reply. Thanks very much for that. So maybe we can now go to the presentation and see that. Okay, so there has been some problems, I think, with the poll. Yes, so I think if the poll said, you said no, you did not visit the question. Oh, sorry, you did not visit the KSP, then you wouldn't have the second option, right? Okay. All right. Okay. Anyway, we're not giving prizes on this poll, so just to give an impression. Okay. Thank you very much. So so let me go to the presentation. So I'm a staff member of WHO. I have no other conflict of interest to report. So the knowledge sharing platform came about from a need to have a one-stop access to our guidelines and our implementation aids via online sources, and to have access to the consolidated guidelines, the implementation handbooks, and the training materials. So alongside the development of the knowledge sharing platform has been a consolidation of our guidelines in these 6 modules. So there's a prevention module, screening module, diagnosis, treatment, children and adolescents, and comorbidities. So, sorry, I'm going backwards now. Okay, so the knowledge sharing platform presents itself on the website and as an application for mobiles. You can access the pages that I will be showing via these QR codes that are on the screens, so that you can also follow a bit better maybe after the presentation. So the knowledge sharing platform has these 7 main sort of features in it. There's access to guidelines, handbooks, and the training, but then also to a quick search function, a recommendation map, and then options on login for people to bookmark and customize the content to their need and having a kind of personal space. So some of the more recent changes to the knowledge sharing platform include a reordering of the guidelines and handbooks using these bookshelving functions. You can see now that there is much more content than there was 1 year ago. Also, we have started to produce different language versions now. So you'll find some content in French and Russian and Spanish. Also in the quick search function, you'll see some rapid sort of presets to some commonly used functions such as algorithms, the drug dosage schedules, and we'll have something similar soon research gap pages of the guidelines. Something that also was populated since our last since the union last year has been the training catalog. So we have 3 learning courses here, one on drug-resistant TB treatment, on rapid diagnostics, and TB preventive treatment. And these are sort of training modules for people who are at decision-making level. So they are long trainings, lasting 6 to 8 hours to complete, and then you have an option at the end to download the certificate if you finish the the final assessment with at least 80% success. And also for login functions, we have the possibility to bookmark your content and have all the bookmarks in one place, and also to customize PDFs. So this was a function that we had already presented last year. I think it was one of the reasons why the KSP was created, because people were asking to have, let's say, the possibility to customize across different documents. So it's a feature there which is available, and maybe for those who are not familiar with it, it would be good to go and explore how this can be done, and then you can find your own sort of bespoke documents in this site on the customized PDF. And we have also put in a feedback function on every page. This is accessible, so if you find bugs or problems, yeah, I think someone needs to mute because there's an echo. Okay, so you can also put your name and email. If you want, you can put in the website if there is something on a particular website, and you can send it to us for as easy feedback. And likewise, the feedback is available on each on the widget that it comes with the mobile app. So again, the mobile apps for both iOS and Android have been refreshed since last month with new content. There is a possibility to see some content as well already in French, also on the with a French interface. So there will be more languages added in future. Alongside those features, there's also a screening algorithm, an interactive algorithm that you can see here on the last screen of these 3, and also a drug dosage calculator. So we will extend, as it is right now, it's mostly dealing with childhood dosages, but we will expand this eventually to cover all of the TB drug dosages. So we're monitoring as well the function and the downloads of the KSP. So this is, I think, the download trace for the iOS app. So there has been much more downloads actually on the app for Android, but just to show you that at launch in June last year, we had a spike, and then there's another spike around World TB Day this year in terms of download. So we're putting in also other sort of functions, stats functions on the web pages so that we can monitor as well beyond the app itself. Okay, so one of the features that can be accessible through the KSP is this recommendation map that was built with Evidence Prime. So this recommendation map presents different features. So for each of the modules that you see, the 6 modules, you can click on each of these and find the recommendations one by one. And once you're in the recommendation, you can also access the background sort of information. And since last year, we have also been linking up directly from the recommendations to the evidence tables and the evidence decision tables for the more recent recommendations, as you can see over here. I think another function which is helpful is this export function over here. So if you want to download the recommendations as a list with different functions which you can tick over here for different content, and then you can have them on an Excel sheet over here, and you can do filtering functions or search functions on the Excel sheet so that you can have, let's say, content limited to one module, for instance, or one topic. Okay, another function of the recommendations map is this grid function, where you can sort of cross-tabulate different populations or subjects against the screening interventions. And you have, for instance, this one on screening. And then for each of these cells where there is a number, that is the number of recommendations that there is on a specific population and intervention. And then when you double click on that link itself, you will also get a specific recommendation there, and you have the option as well to export that. So overall, the portal, since its creation in August 2020, has been used by close to 5,000 users, and on average, a user would visit 4 pages and spend 4 minutes on the website. And the recommendation list has been the most popular. The grid has been used more sparingly, and you can see here a listing of the more commonly used sites. One other thing that I wanted to mention is the NTB channel. There will be more in the union about the training modules that we are doing, but apart from the 3 training modules that I mentioned earlier, there's also another one that we have put, and this is for the to understand and use the WHO guidelines on TB. This was a specific request for people who participate in guideline development group meetings or otherwise involved or affected by guidelines, and to understand a bit better the process of grade, which is used for to produce our evidence-based guidelines, and also to understand how that relates to TB and other issues relating to contextualization of our recommendations. So, so the target audience of this is TB practitioners in their wide sort of scope, and there's some of it as well which is open for sort of more lay users to explain a bit better and more sort of simple language about what goes on. So it's a course duration, if you want to do the whole thing, is about 4 hours, and there's possibility as well of certification. See, has been a linear increase in the users of these training on guidelines, and also some mapping of the users where most of them are coming from. Okay, so with that, I would like to thank the many persons who have been involved in the production of the KSP, the recommendation map, the e-learning modules, and also the many experts who have contributed to the content as it is, our technical and funding agencies, national programs, civil society, many patients, and also for the users who have provided feedback. So with that, I would like to pass it on to Caroline to launch the last poll, and I hope that that works a bit better. So over to you, Caroline. Okay. Okay, so the question is, which part of the knowledge sharing platform do you think would be most useful for your work? So I let you go at this, and I hope we'll have a good participation. So just one question, so I think we're safe. Okay, filling up faster now. Don't worry, it's completely anonymous, so we're not trying to see who's answering what. Don't worry. A bit more. Let's try to get to 200 maybe. We're still within time. Okay. Getting there. Okay, 190, we're not far. Come on, a bit more. I think there are about 270 persons online. Okay, so I think we can publish the poll. We're at 199, 200. There we go. Okay, so there's been 30%. Well, 35% said all of the above, right? And 30% said guidelines pages, 16% operation handbook, 6% training catalog, 5% quick search, and the recommendations map 7% and 35% all of the above equally. Okay, so I took a snippet of this because it's quite helpful actually for me as well. Thank you very much, everyone. And if there are more questions as they come, will you send us all the slides from the session today? I hope so. We can do that for sure. Okay, over to you, Matteo, then, and Norbert. Thank you very much.
Thank you very much, Dennis. Great presentation. This is definitely a very valuable tool that we have here at WHO. And if for those 40–50% of colleagues who have not seen it yet, we really invite you to spend time looking at it, download the app, because there you can really find all what is coming out new from WHO in terms of guidance on tuberculosis throughout the spectrum. So it's a very important tool that we have. Thanks again, Dennis. Please, if you have any questions, raise your hand. If you have any questions for Dennis on the knowledge sharing platform, we do have time, or type your question in the chat. Maybe I do have a question for Dennis, if I may, Dennis. What's coming up new in the platform? You showed us how it's built, the structure, what it contains. Is there anything that is coming up new in terms of that you want to highlight here?
Yeah, thanks, Matteo. So I think in terms of new, there will be new content added to the training catalog. I think some of the speakers might mention this as well. There will be new language versions coming out. So we're working as well on an interface for Arabic. And there will be quite a bit of new content. I think first content in Arabic will come out before the end of this year. There will also be a desktop app, actually, which will be sort of downloadable on computers and which can be activated via internet. There has been a technical issue, so we have not published it earlier. Unfortunately, it's been ready for quite some time. We're trying to get around the technical issue, but it will be available for the IBM computers for now. But also for Mac. What else? But I think most of the next year will be focused on uploading new content, new languages. Yeah, and I welcome as well that people use the feedback tool to be able to give us some feedback as well on areas that would be. So I'm seeing some questions. I hope the material will be available in Portuguese. So we're limited to the official UN languages. So unfortunately, Portuguese is not one of them, but we can see maybe with the PAHO region, if this will be possible as well, to have some of the content translated into Portuguese. So Darcy, hi. Are there push notifications possible when new content is added? We're working on this, yes. We're working to try and feature this on both the website and the app. Does the app get automatically updated when there is new content? Yes, if you have the background sort of update, it will update automatically. What about the summary of countries included in high-risk groups? Can it be added like a card in the apps? So this will be, so there is another app which is for the global TB report, which will come out at the end of this month on the 27th of October. And that will have other functions related to sort of the epidemiological groupings of countries and other things. So that will be there. this app is really focused on evidence-based guidelines and other publications that are linked to the guidelines themselves, so the operation handbooks and the training modules that relate to them. Then there are many other publications that we have as WHO Global TB Program, which feature in other tools. Yeah, why not in Portuguese? It's because it's we limited this to the official languages of WHO, which do not include Portuguese, unfortunately. But of course, I mean, if there are specific requests in countries, we can see how to deal with this.
Yeah, thank you very much, Dennis. I think you have answered all the questions in the chat. I don't see any hands raised. We do have one more moment if there are additional questions. Yes, there is another question. Dennis, you can read it or want me to read it? Dr. Kira.
Can we introduce some online platform for regimen design or any clinical consultation? Okay, so one of the tools that is on this site, one of the drug doses schedule tool, if you try it out, it will give you can choose from the drugs that you want to give for the sort of older, longer type regimens. For the shorter regimens, it's not yet there. I think we can envisage other sort of interactive tools that we can design in future, which would also cater for sort of standardized regimens, first line, or now even the sort of MDR, new MDR regimens on a sort of on an interactive basis. So this is something that we are thinking for the future as well, but we don't have fixed plans right now for the immediate future. Does the app work offline? Yes. So the desktop app will be working a bit like the mobile app, my smartphone app, and it will be for the computer. So it comes from a request by countries, understandably, where internet access is erratic, so that they could have something which they can use even while offline on their computer.
Okay, thank you very much, Dennis. Thanks a lot for sharing this important presentation with us, and thanks a lot for all these questions. We will now move on to the next presentation, and let me check one moment if Dr. Ndjeka is with us. Yes, over to
yes,
Norbert.
I'm here.
To introduce Cecily's and Avinash for the next presentation.
Okay, no, thank you so much. I have technology challenges here. So our next two speakers are Dr. Cecilia Miller. Miller is an epidemiologist and technical officer in the TB Prevention, Diagnosis, Treatment, Care, and Innovation Unit within the Global TB Program in Geneva. Her focus is on screening for TB and digital innovations in TB care. Prior to joining the World Health Organization, she worked for 10 years in the Center for TB at University of California in San Francisco, focused on clinical and programmatic research on TB diagnosis and screening interventions and in the global health education. Dr. Avinash Kansha is currently working as medical officer in TB prevention, diagnosis, treatment, care, and innovation as well within a global TB program. And she's concentrating on TB policy development and country support for implementation of TB preventive treatment and TB infection prevention control. His medical degree was focused on preventive and social medicine. And prior to joining the World Health Organization, I worked as field consultant for National TB and HIV programs for India for 10-year period. So the two colleagues will talk to us about current recommendations of TB screening and prevention. Please switch off mute yourself if you're not speaking. So over to you, Dr. Miller and Dr. Kanche. Please share your screen.
Thank you very much. Can you hear me and see my screen okay?
Very clear and loud. Go ahead.
Great, thank you. So thank you very much for having us. I am delighted to speak alongside my colleagues. Again, my name is Cecily Miller, and I will be speaking today on the current recommendations for TB screening and implementation guidance. So we'll have two parts to this talk. I will give this first part focused on systematic screening for TB disease, and then I'll pass it on to my colleague Avinash. I have no conflicts of interest to report. And just to specify up front that for this talk, for these guidelines, we define systematic screening for TB disease as the systematic identification of people at risk for TB disease in a predetermined target group by assessing symptoms and using tests, examinations, or other procedures that can be applied rapidly. So again, we're looking at TB disease, not TB infection. And so some key features of TB screening interventions are that they should be done systematically to an entire selected population. They should be done using a highly sensitive screening tool to pick up those people that have the highest probability of having TB disease. And they need to be followed with a proper diagnostic evaluation using a test with a high accuracy, bacteriological test, in order to confirm a diagnosis or rule it out. And they need to follow established ethical principles that are specific to screening. So the objectives of TB screening are twofold. Number one, there are ways in which screening can benefit individuals by detecting TB early or by helping to prevent it. We see evidence that screening can help increase access to treatment or preventive care and thus reduce delays in diagnosis and thereby also improve treatment outcomes. And we also see clear evidence that screening can help reduce costs for patients with TB, and including it can reduce the risks of catastrophic costs for TB patients. And we know that people who suffer from TB are some of the poorest and most vulnerable in many communities and populations. So this is really key. But we also see evidence at the community level that TB screening can increase detection of prevalent TB and thereby reduce the prevalence, the transmission, and future incidence of TB. So because of these, TB screening has a few different roles in global TB care. Number one, it can help address the global case detection gap, as we call it, the missing millions. And we all know well now, of course, that globally there's a large portion of people who are not diagnosed every year, and that the COVID pandemic likely made this worse. And we know that in 2020, there was a 40% gap in the detection of the estimated number of people who came down with TB and the number of people who were diagnosed and reported to WHO. And of course, we know that we still lag in our progress in achieving targets of the high-level meeting and the NTB strategy. Also, TB can help us preferentially reach the most vulnerable populations. And again, so those are often those populations that have the highest risk for TB, often have the least access to care. So this is the role that TB screening can bring to bridge this gap. And lastly, TB screening is the essential first step before initiating TB preventive treatment, which is, of course, another life-saving intervention that my colleague will speak more about. So here's just a diagram showing how TB screening on the bottom can hopefully help overcome many of the barriers that patients face in the patient-initiated pathway, which is there on the top. Excuse me. Excuse me, apologies. And then lastly, we see how it is the first step prior to initiating preventive treatment. Okay, so because of these reasons and roles that TB screening can provide in global TB care, the WHO in 2020 convened an expert group meeting to update the guidance with the goal to look at some novel tools for screening and to provide more implementation guidance specific to certain risk groups and populations. And the resulting updated guidelines and operational handbook, which you can see here, were released in March of 2021, and you can access them at the knowledge sharing platform that Dennis just described, or at these barcodes or website. Yes, here's the knowledge sharing platform. So now I will just briefly summarize the recommendations in these updated guidelines and a bit of implementation guidance. So first off, there are 4 populations in which TB screening is strongly recommended. So these include household and close contacts of TB patients, people living with HIV, minors exposed to silica dust, and prisoners. And so for these 4 populations, screening always should be conducted. The question is just how. What tools and algorithms should be used? What's the implementation model, with what frequency, etc. Many of these questions we do not have specific recommendations on, and it's more a matter of local context and resources available. TPT should be provided when appropriate. And of course, we know that the first 2 populations here, contacts and people living with HIV, are primary populations to consider TPT. Again, we'll talk about that a lot more later in this talk. And of course, monitoring and evaluation needs to be conducted. We also have populations for which screening is conditionally recommended, which include people with untreated fibrotic lesions, people with risk factors for TB who are seeking healthcare in settings that have a 0.1% prevalence or higher. So this can include people who are malnourished, people with diabetes, a previous history of TB, other chronic lung diseases, or other risk factors. Again, this is also very context specific, depending on the epidemiology of TB and other health conditions in a particular setting. We also have a recommendation that screening could be done in communities that have structural risk factors for TB and have limited access to healthcare. And this includes risk groups such as urban poor communities, homeless populations, refugees and migrants, or other vulnerable or marginalized groups. And again, this is specific to particular contexts to determine which groups should be prioritized for screening. And lastly, we now have a recommendation that screening can be considered in settings with a 0.5% TB prevalence or higher. And again, for all of these populations in which screening is conditionally recommended, there needs to be prioritization and a consideration of the benefits and risks of screening and the opportunity costs for other TB or other health interventions. So we now have a number of tools that are recommended for screening. So first off, symptom screening remains an option that can be done either by screening for prolonged cough or for any of many TB symptoms. Symptom screening is very feasible and easy to implement in just about any setting and easy to repeat, but it is not highly accurate. So we also have some tools now that have higher accuracy, but higher resource requirements. So the first off is chest X-ray, which we see on the right, and we know that this is probably the most sensitive screening tool that we have. And it can detect TB oftentimes before the onset of symptoms. We see evidence of this from prevalence surveys. And we also now have a recommendation that WHO recommended molecular rapid diagnostic tests such as Expert or TrueNat can also be used for screening. Importantly, we now also have for the first time a recommendation that CAD, or computer-aided detection for the automated interpretation of chest X-rays, can be used as an alternative to human readers for TB screening or triage in all individuals who are aged 15 years and older. And this is a very exciting development because we see that this can really expand the scope of screening and triage, where human resources and trained personnel for reading chest X-rays are limited. So there are some considerations for implementing CAD. On the left, you see a figure of the CAD threshold score, which is the score that is set to determine what will be considered an abnormal chest X-ray. And the setting of the threshold is very important to consider because this dictates what the sensitivity and specificity of the screening will be, and thereby what the yield of the screening will be, and also what the costs will be implicated with the diagnostic testing that goes along with this. So there are some resources to help countries or new implementations calibrate CAD for a new setting. On the right here, you'll see a toolkit that was released by the TDR program, which is called Calibrating Computer-Aided Detection in new settings. You can find it at the link that's provided here. And just to say that this tool can help guide users to collect the required data to conduct a calibration study for CAD. And it also comes with a web-based tool to help analyze the resulting data from such a study and produce ROC curves, which you can see here, which essentially will tell the user exactly what the sensitivity and specificity of your CAD would be at any threshold that you choose, as well as what the resulting implications would be for costs for diagnostic evaluation and yield for screening. So we also have some tools that are recommended specifically now for screening people living with HIV. This includes the WHO recommended 4-symptom screen, which has been recommended since 2011, is again a very easy to implement and feasible test. But we've also seen that it sometimes has suboptimal sensitivity in certain subpopulations, meaning it's not detecting all of the prevalent cases. And we also see sometimes it does not have optimal specificity, meaning too many people are screening positive. So we now have some additional tools to help for screening with people living with HIV. First off, we have C-Reactive Protein, which is down on the left here. This is a blood-based test, which can be performed in many settings with just a finger prick spot of blood as a point of care test. And this test that we see can help improve the specificity of screening, particularly for people who are newly enrolling on ART care. Chest X-ray on the top right here is also now recommended for screening people living with HIV. And again, this tool, as with all other populations, improves the sensitivity of screening. So this is a really essential tool if current screening practices are not detecting all the prevalent TB in people living with HIV. And lastly, WHO recommended rapid molecular tests are now also recommended for screening people living with HIV. And in fact, they are strongly recommended as an initial test for people who are severely ill, inpatient people living with HIV in high burden settings. Lastly, there are tools recommended for children, the two populations of children which are recommended for screening. These include contacts, for whom symptom screening and chest X-ray are recommended, and children living with HIV, for whom symptom screening and screening for contact with TB patients is recommended. We do not yet have sufficient evidence to recommend the other newer tools for screening in children, but we hope this will develop very soon. So I'll just briefly say that the implementation guidance provides a lot of description about different algorithms that can be used to combine these screening tools together with diagnostic evaluation in the specific populations that I've discussed here today. And we also have some digital tools to help with planning and implementation. The Prevent TB app on top here is a mobile app that facilitates implementation of screening, which I think my colleague will discuss more as well for TPT. Screen TB is a web-based tool that assists countries with estimating the yields and costs of screening, which helps with program planning for screening at a national level. On the bottom right here, you see some figures which help compare the yields and the costs for screening across risk groups and across different algorithms. So this can help to create to develop national plans for screening. And lastly, I just want to mention that there will be a new training module of screening coming out in 2023. So look for that soon. All right, and now I'll hand over to Avinash. Thank you.
Thank you very much, Cecily. Can you move the slide, please? Yeah, so as Cecily mentioned as well in her talk, that TB screening is the essential first step before starting TPTs, and most of the populations that are considered for TB screening would also benefit from TPT were based on risk versus benefit analysis that should happen in the context of the countries. In the subsequent slides, I will be covering the recommendations that came out in 2020. So, and most of them have remained unchanged, except for one that I will mention a bit later. Next slide, please. So, as you may be aware, the consolidated guideline on TB preventive treatment that was published in 2020 had 18 recommendations, which followed a cascade of care approach, and there were recommendations across the cascade, starting from identifying people at risk of TB who should systematically be considered for TPT, steps to rule out TB disease, role of tests for TB infection, and there are various options for TPT beyond the 6 months isoniazid that we had before. Next slide. Next slide. So the target populations for TPT, first and the most important would be people living with HIV, and TPT should be considered among them regardless of their ARV status, pregnancy, history of TB treatment, level of immune suppression, or availability of tests for TB infection. Among infants exposed to HIV, a contact with TB should be taken into account, and for children, TB disease should be ruled out before TPT is considered. Among children living with HIV as well, TPT should be considered even if they have completed a course of TB treatment. Next slide. The second group to be considered systematically for TPT is contacts of TB patients, pulmonary TB patients bacteriologically confirmed, and children under 5, individuals more than 5 years, and individuals who are exposed to multidrug resistant TB. Next slide. And in addition, these are the populations that should be considered systematically for TB screening and TPT. People having clinical risks, such as those on anti-TNF treatment or dialysis, or are being considered for organ or hematological transplants, or those who are having silicosis. Prisoners, healthcare workers, immigrants from countries with high TB burden, homeless, and people who use drugs should also be considered for TPT based on the country context. However, as of now, systematic testing and TPT is not recommended among diabetics, alcohol users, smokers, and those who are underweight. And this is more due to lack of evidence at the time of the guideline development. But in the countries may consider TPT if one of the above risk factor is also present in these populations. Next slide. Ruling out TB is largely symptom-based. Next slide. And for people living with HIV, the 4 TB symptom complex should be used. And in children, poor weight gain and history of contact with the TB patient is also important. And contacts more than 5 years and other clinical risk groups, lack of any TB symptom should be the criteria before TPT started. Chest X-ray is also recommended among PL-HIV who are on ART or contacts who are more than 5 years of age. Absence of any of these clinical symptoms or chest X-ray abnormality should be used to rule out TB before starting TPT. So in Cecily's presentation, these symptoms were used to rule in TB largely, but before TPT, these symptoms and as well as the chest X-ray is considered for ruling out TPT, and the negative predictive value of lack of these symptoms is very high, and even TPT can be considered even if the X-ray is not available. Next slide. Next, test for TB infection. You may have recently noted communication from WHO. The consolidated guidelines on tests for TB infections were released recently. In the previous guideline, we had a recommendation on TST and or IGRA, and that they are equivalent and can be either can be used as a test for TB infection. But in addition, now we have 3 antigen-based skin tests, which work on IGRA principle, are also now recommended. But tests are not required among people living with HIV or children who are under 5 years and contact of a TB patient. So in these 2 groups, tests are not required, but in other groups, tests may be considered based on availability. Next slide. Tpt options. In the past we just had 1, but now we have at least 5 options, including 4 shorter Tpt option. The 3-month isoniazid rifampicin weekly regimen, 3 months isoniazid rifampicin daily regimen, 1 month daily isoniazid rifampicin, the 1 HP regimen, and a 4-month rifampicin only regimen. The 36 months daily isoniazid regimen continues to be recommended in the highest transmission settings. Next slide. Among children, given the lack of availability of rifampicin and lack of understanding of appropriate dose for children under 2 years, 3RH remains a preferred regimen, particularly under 2 years of age, as well as younger children. And if these FDCs are not available, INH dispersible isoniazid could be an option. Children living with HIV, 3HP could be considered only among those who are not on protease inhibitors or nevirapine. Alternatively, 6 months isoniazid, preferably using dispersible formulations should be used. And for older children, 3RH adult formulations can be used, or 3HP. Next slide. Briefly regards availability of rifampicin, there were some challenges over the past couple of years, but now the availability of rifampicin is easing. We have two generic manufacturers who are either approved by the ERP, the Global Fund ERP, or the WHO pre-qualifications. There is a 150 milligram single formulation from Sanofi, FDCs of rifampicin and isoniazid 300 milligrams each from McLeod's, as well as an FDC that Lupin is manufacturing along with a 300 milligram single tablet. Next slide. So just to give a glimpse of the costs and the capacities that are existing now for rifampicin, a course of 3 HP costs around $15 with the use of FDCs, and it could be a bit higher if single formulations are used. And the manufacturing capacities of the generic manufacturers I mentioned is quite high. More than 2 million packs per manufacturer. So it's enough supplies on the market right now, and we are looking forwards for increased demand, so the costs go further down. Next slide. So we also have a recommendation of TPT use among contacts of drug-resistant TB patients. However, with some additional consideration of assessing the intensity of exposure or the drug resistance pattern of the source, and use of tests among these population. And levofloxacin daily is recommended along with ethambutol or ethionamide for 6 months. Next slide. these are the three trials that we are waiting to see the results from to strengthen the recommendation that we have. The earliest that we expect to come is BQuIN, which is looking at all age groups and testing use of levofloxacin among all age groups. And the results are likely by the end of this year. And early next year, we are expecting results from TB CHAMP study, which is looking at under 5 years age group and again levofloxacin. So based on these recommendations, the existing WHO recommendation could be strengthened. Next slide. And Dennis talked about this. I'll just mention in brief what relates to TPT. Next slide, please. On the knowledge sharing platform, as Dennis mentioned, there is this recommendation map, and you can access each of the recommendations we talked about, and details about the evidence that has gone behind and the implementation consideration in some of the behind some of these recommendations. Next slide. Yeah, next slide, please. And there is a course on TPT e-learning module that and average time is about to complete the course is about 7 hours, but this can be taken in multiple sessions, and it covers all the recommendations, all the implementation considerations and planning considerations that the national programs or consultants may want to consider. Next slide.
That was a medical case now.
Yeah.
Please mute yourself if you're not speaking. Thank you.
Yeah. So despite WHO recommendations on TPT for a long time, particularly among children and PLHIV, the uptake hasn't been optimum. And these are the most often asked questions. Does TPT work? Does it work in high burden countries? How long it protects? Do we need to repeat a course of TPT? Will it not increase drug resistance if we use just 1 or 2 drugs? Is it safe? Is it safe in pregnancy? Is it safe to use with other ARVs? So all these are relevant questions that should be asked, but none of them warrants not offering TPT, and the reasons and justifications for them you can find in the operational handbook that I mentioned next. So like all other guidelines, next slide. So we have an operational handbook for programmatic management of TPT as well, which looks into each of these questions that I listed and provides the evidence that exists till date to answer these questions and make a justification of for programmatic scale up of TPT. And in addition, there would be chapters that are dedicated for strengthening contact tracing, drug dosages, management of drug interactions, safety, as well as monitoring adherence and some program indicators. Next slide. And to strengthen the monitoring and evaluation, this is one tool that WHO has developed. It's a digital platform which comes with 3 key features: a mobile application, but along with that, a smart setup that helps programs or projects to develop their own application based on the need for data capture, and it also provides some generic indicators on a dashboard. And you can find more information and access using these QR code. Next slide. I'll stop here and thank you all for patient hearing. Thank you.
Thank you. Thank you so much, colleagues, for a wonderful presentation. Indeed, you highlighted the importance for early detection of tuberculosis, and you took us through the new tools that are available for detection, for early detection and prevention tools. So we're running short of time. I'm going to ask colleagues to send questions on the chat. I've been seeing a number of questions, and encourage speakers to respond directly. to those colleagues, and we'll take our next speaker, who's going to talk to us about current recommendations on TB diagnostic. And the speaker is Dr. Nazir Ismail, who's the team leader for TB prevention, diagnosis, treatment, care, and innovation unit at the Global TB Program. Nazir is responsible for development of global policies, norms, and standards in the field of TB diagnostic and laboratory strengthening. Used to serve as a head of TB Center for Tuberculosis at National Institute of Communicable Diseases in South Africa. He's a medical doctor by training, specialized in microbiology, pathology, with special interest in novel diagnostics, epidemiology, public health, responses, and transmission of TB. He used to serve as well as a member of National Clinical Advisory Committee for TB or drug-resistant TB in South Africa. So I'll ask Nazir to talk to us about current recommendation for TB diagnostics. Over to you.
Thank you, Norbert, and good morning, good afternoon, and good evening to everyone. I'll just share my slides. Okay, Norbert, can you confirm you can see and hear me? Excellent.
It's clear. Put it on our slideshow mode.
Is it on slideshow now?
Not yet.
Not yet.
Yeah, it is.
It is. Okay.
Oh,
right.
okay. Good.
Okay,
yes.
excellent. Thank you very much. Right, so I'll be covering the topic on the current WHO recommendations on TB diagnostics and presenting on behalf of the diagnostic team at the Global TB Program. No conflicts of interest to declare. Just as a brief background, I think we can appreciate the importance of diagnostics along the pathway of care from health, infection, disease, and cure, and diagnostics along this journey is quite important. In terms of the guidelines that are developed by WHO, it follows a evidence-based process and a great development process to ensure that we can identify the required evidence, assess it based on the certainty of evidence, and then moving from evidence to recommendations following a specific process. Specifically related to diagnostics, we often look at diagnostic accuracy, but also end user values, preferences, economic aspects, feasibility, and acceptability. So moving on to what's new and what's old. So in terms of the WHO guidance on diagnostics for TB, we've just issued updated consolidated guidelines and an operational handbook on tests for TB infection. So you see that on the left. Those are now in addition to the ones on the right, which were related to diagnostic tests for TB detection. The new guidelines and operational handbook are available on the WHO website listed below, but not yet on the TB knowledge sharing platform, and that should be uploaded fairly soon. So going into the new guidelines, as I said, these are consolidated guidelines and a new module that's been developed related to TB infection tests. We have 3 chapters in this latest consolidated guideline. The first is the new recommendations on tuberculosis antigen-based skin tests for diagnosis of TB infection. And then chapter 2 relates to a consolidation from previous guidelines on the use of TST and IGRA for TB infection. And the last relates to the use of those tests for the diagnosis of TB disease. And that dates back to 2011. So just a quick walkthrough in terms of recommendations for tests for TB infection. The first recommendations were issued in 2011. I think prior to that, TST was widely used and IGRAs were new at that point in time. And the first recommendations related to IGRA were issued and included the quantiferon gold, gold in tube, and the T-spot TB assays. In 2018, and we heard from Avinash just now around the prevention guidelines. So those were updated to look at both TST and IGRA, and these have now been consolidated in the latest guidelines. Of note, the quantiferon gold and gold in tube had been discontinued, and we had a meeting in 2021 was a technical advisory group reviewing evidence for alternative IGRAs, and that's when the Quantiferon Plus and the one-type TB IGRA test were added to the list of IGRAs. And what I'll focus on in the next few slides as well is around the latest recommendations on the new skin test for TB infection. So looking at the at least the TST and IGRA recommendations, which were consolidated from 2018. The meeting was held in 2017 and included the TST, QFT Golden Tube, and the T-Spot. And the recommendation here was that either a TST or interferon gamma release assay can be used for TB infection. It was a strong recommendation with very low certainty of evidence. And importantly, to appreciate that, as Avinash highlighted as well, that testing for TB infection is not necessarily mandatory for all groups. For example, people living with HIV may not need a test when it's not available for TPT provision. In terms of these recommendations, there was no strong evidence that one class of tests should be preferred over another, and operational considerations would influence the decision. And this recommendation is taken from the prevention guidelines. So moving on to the new recommendations that's been issued, we had a meeting in January, late January this year, reviewing the evidence on a new class of skin tests. So like for half a century later from the classical Mantoux test, we finally had evidence on a new class of skin tests, which use MTB-specific antigens. So using the ESAT6 and CFP10 antigens, which are commonly used in the IGRA assays that provide the high specificity compared to TST. So these three products that were considered within the guideline development process was CyTB, the DIA skin test, and CTST. And the CYTB has just been registered in India, and DIA skin has been registered in the country for about a decade thus far. The recommendation issued following the GDG process was that these MTB antigen-based skin tests may be used to test for TB infection. It was a conditional recommendation for the intervention with very low certainty of evidence. This expands the number of testing options available for testing for TB infection beyond just TST or IGRA. Most of the data was also included head-to-head studies comparing the current class of tests to TSTs and IGRAs. The GDG extrapolated the recommendations to also include people living with HIV, children and adolescents under the age of 18, and also people who have been vaccinated with BCG. So some of the data also included data from high-burden countries where BCG is widely used, and the specificity was highly comparable to IGRA in those settings. We also looked at the safety of the products. This was looking at it as a class, and overall no major safety concerns were identified. However, a formal evaluation of each individual product by a regular agency is required before introduction of these tests, as they are in vivo tests. And lastly, just on these TB skin tests, because of the manufacturing process for these types of technologies, they're far more standardized and use more modern technology, making them more reproducible and also cheaper to produce. And therefore, the overall cost effectiveness modeling showed that it might be cost saving in some settings. Whoever is, okay, thank you. And then the last recommendation back from 2011 related to the use of these infection tests, the TST and IGRAs, for use for the diagnosis of TB in adults. So I think there's been a strong negative recommendation, and this is still retained. I think we have highly sensitive tests for the diagnosis of active TB, and such tests should not be used for that purpose. So moving on to the next document that's been issued companioning the consolidated guidelines is the accompanying operational handbook. This is also a new document, and the different chapters within the document will aid countries and users of the new test for TB infection as well as the existing tests. So the first chapter really links with the prevention guidelines and the populations eligible for TPT, which Avinash has nicely covered. The second chapter deals with considerations of who to test or not to test, and the overall approach to testing patients. The third chapter relates to the 3 classes of TB infection tests, both the TST, the new TST, which is the MTB specific one, and then the IGRA tests. And the fourth chapter deals with the programmatic implementation of TB infection testing, looking at a more broader systems-based requirements for implementing a TB infection program. And then we have 2 annexes that provide more details on the tests themselves. So just a few highlights. Within the document, we have, for example, the TB infection cascade, trying to look at how the TB test fits into the bigger cascade. Also, like what Avinash had showed, whether when you're looking at the TB testing and what are the steps in terms of practically site visits and follow-up visits, etc. So recognizing that these skin tests obviously may require follow-up visits anyway. And then in terms of the annex, like I highlighted, we do have a step-by-step process for a description of how the skin test should be done step by step. And this is consolidating the TST, but also the new products for Tbsts as well, to show a systematic way of following through the testing. And then in the second annex, we have the step-by-step for each of the 3 WHO recommended IGRAs that are currently approved. Right, so quickly moving on to, so there was all the new work related to the new modules related to tests for TB infection. I'll just briefly touch on the guidelines related to diagnosis of TB disease. And this was from last year, from the 2021 update. So a significant shift was related to class-based recommendations, restructuring of the document to think of more around the patient flow, and then specifically the 3 new class of tests that were recommended in 2021. So this is the structure that was put out in the latest guidelines on tests for TB disease, structured into 3 groups of products, which is first initial test for the diagnosis of TB with drug resistance detection. So we had Expert and the TrueNet platforms, and a new class of technologies was added in 2021. Chapter 2 relates to those that don't have drug resistance, but are also primary tests for the diagnosis of TB, which include the LF-LAM and LAMP. And then the third is around follow-on tests, and those we've added 2 new products into that classification. So on the first one, just I'll briefly touch on this. We've added a new class of rapid diagnostic test for the initial diagnosis of TB among people with signs and symptoms of pulmonary TB. This new class of tests detect both rifampicin and INH up front. And the types of products that were considered were the Abbott real-time systems, the BD-MAX, the Bruker-Hain, and the Roche Cobas system. So a system is fairly familiar with both in the world of HIV and also COVID. So established platforms that are now offering tests for TB, and importantly, also detecting INH resistance up front. The group did positively recommend their use, and they now add to the repertoire of options. But the recommendations were limited to patients with pulmonary TB, but extrapolation was made for people living with HIV, adolescents, and children. The other important new addition was the review of a new first product in the class of low complexity automated nets. And the first product was the Expert XDR cartridge. Overall performance was also very good, and recommendations had come forward to approve its use in bacteriologically confirmed pulmonary TB, meaning that it would be a follow-on test from the initial products that are being recommended. And the test could be used for INH and fluoroquinolone resistance detection, both in rifampicin resistant, but also rifampicin susceptible TB. And then the test also detects ethionamide and amikacin resistance. And among rifampicin resistant cases, the group also recommended the use of these products. So both the previous group and the current one were conditionally recommended, as most of the data was primarily on diagnostic accuracy. For this Expert XDR cartridge, the recommendations were also extrapolated to extrapulmonary TB in addition. And then the new test that's come forward is a an LPA type of test that can detect pyrazinamide resistance. The overall performance was fairly good, but limited in a sense that it can only be used, at least based on the data we had at that point in time, on culture isolates. But anyway, a molecular PZA test is a definite welcome. So just to finish off on the active disease test groups, as Avinash and I think Dennis had highlighted in the beginning, we do have training modules now, and the diagnostic ones on the rapid diagnostics for TB detection are available. It's 6 to 7 hours and has been well received, and encourage those that are interested to go through it. It has some practical videos on the products themselves and how to use them, but also the practical steps of implementation and some case studies as well. So with that, just to thank the Global TB Program and the diagnostic team specifically, the guideline development panel members, steering committee, and all the contributors, as well as NTP and all the other relevant stakeholders as well. So thank you for that.
All right, thank you so much, Nazir, for an excellent presentation, but also for saving us a bit of time. I'm going to ask you to go to the chat. I'm on my cell phone right now. I can't really have access to all these questions. If you could go through them and respond to some of them, and the rest, of course, you could do them in writing, you know, to all the people who want to know.
Yes, certainly. So I will keep an eye on the chat.
Okay.
Yeah, so any questions, most welcome. Yeah.
Yeah, keep an eye on the chat. Maybe I will ask something myself. The test on pyrazinamide.
Yes.
I'm not sure the importance of such a test. I know that we've been struggling in the past to have this done routinely, and as we move towards the new agents, we're now going to get that. I don't know. I just want to hear your own views around the pyrazinamide testing, resistant testing.
Yes, thanks, Norbert. So yeah, I think you're right. I mean, in terms of the rapid changing space on the treatment side, I think, you know, for years, PZA, tests were in demand, especially with the shorter classical RR regimens. But I think with the BPAL and those kinds of regimens, you're right, it's becoming less relevant. However, I still think that there might be still relevance in cases where, for example, patients almost require like a third-line regimen where they are maybe not suitable and they need individualized therapies, and therefore, I think a PZA type of test may be useful. Yeah, but you are correct that PZA has limited value right now, at least going forward. Yeah.
Okay, thank you. Are there questions on the chat?
Okay, so the first question is the new Tbst available for procurement on GDF? So currently not yet. So I think there's a process for that to go through. It needs to go through a quality assurance process for each product. And that requires regulatory approval through the medicines component. So just also to note, I think, and for people to be aware, the new TB skin test, although it's a diagnostic test, it's an in vivo test, meaning that regulators will not review this product under a classical IVD process, but through a medicines process primarily, which would require submission of safety data. But I know, I mean, the product is approved in India, the CYTB, and they are pursuing WHO pre-qualification. Yeah. Okay, I see another question on why there is a shortage of first-line LPA and second-line LPA cartridges. Yeah, so I think if it's a localized issue, we've heard of issues around supply issues around BD for DST. We've heard around expert cartridges recently related to the rebound. I haven't heard much about the LPA first line and second line kits that are running short. But I gather, like for most products, the recovery post-COVID has been very slow for many companies, and I think reagents have been short for some components. But we could investigate, but it's the first time I'm hearing issues around the first and second line LPA. But having said that, I think we should also be wise to the new developments. I spoke about the XDR cartridge, which is really a high-performing test that can be decentralized. And consideration for also those types of products need to be considered. And I don't recall there was any major shortages with the XDR cartridge currently. So if there is obviously limited availability, then alternative tests should be considered.
Can we take
Anything?
the last question? Need to go for a break.
Yeah, sure. So I see any new, nothing new coming up on TB diagnostic guidance in the near future. So yes, so we currently will be reviewing evidence on the use of next generation sequencing for drug resistance detection. And that should be coming up fairly soon. And we should have hopefully some guidance next year. So I mean, there's a vacant gap related to the new and repurposed drug. We're acutely aware of that. And we'll be evaluating evidence for that. We can't confirm anything, but for now, at least we will be looking at that product.
Okay. Yeah, no, thank you. Thank you so much, Nazir. Colleagues, we can continue to interact online. It's been really wonderful to hear those ideas. It's really exciting these days. We get so many directives from the World Health Organization. I mean, in the past, we'd wait for years to get one input, and now it's really a lot, and the effort as well to make us knowledgeable about these things. I'm not sure whether there are still valid excuses not to be knowledgeable, because information is there, is available to us. And let's take a break, body break, 5 minutes, and then we'll come back. Thank you so much.
Thank you, participants. We'll break for 5 minutes. I recommend that you do not log off from the meeting. And I will display a countdown slide for your convenience so you know when to come back. Thank you. Welcome back. The course will now resume.
Thank you very much, Caroline, and thank you everyone for coming back after this short break. I'm very glad to see that there's still a very large number of colleagues in the room. We go straight to the next presentation, next presenter. And I'm going to introduce Dr. Fouad Mirzayev, who leads the treatment team at the WHO Global TB Program. Fouad joined WHO in 2004, and his main areas of work are the treatment of TB, including drug-resistant TB and drug-susceptible TB. And he's been also leading work on access to second-line drugs and diagnostics. Prior joining WHO, Fouad worked for the International Committee of the Red Cross. Over to Fouad, who will present on WHO latest on guidance on TB treatment. Thank you, Fouad.
Hi everyone. I hope if my presentation doesn't show the full screen, you will let me know.
It's perfect, thank you.
Okay, great. Glad to see a lot of participants in our workshop. My name is Fouad Mirzayev, as Matteo said, leading the treatment team in the Global TB Program here in Geneva, and I will present the current and some upcoming updates of the WHO guidance on treatment of tuberculosis. So just to reiterate, I have no conflict of interest to declare. Okay, so the WHO Global TB Program has quite a long history of developing guidelines on TB care and treatment since early 90s. Several of these guidelines and also many operational handbooks have been updated and consolidated in 2022 during this year. The consolidated guidelines on treatment of drug-susceptible TB present several new recommendations on treatment. The rapid communication on drug-resistant TB treatment announced new recommendations and updates in drug-resistant TB treatment guidelines that are expected to be released end of this year, so quite soon. The new TB care guidelines and the handbook have also been released in the mid-year this summer. So let me go a little bit more in details through these updates that already happened or those upcoming updates, starting from the treatment of drug-susceptible TB guidelines. So this year, the 2022 drug-susceptible TB guidelines consolidate all valid recommendations from previous guidance, but also add two new recommendations on 4-month treatment regimens in adults and children. The existing recommendation of the 6-month regimen that is widely used worldwide remain to be recommended. This is the regimen composed of isoniazid, rifampicin, pyrazinamide, and ethambutol for 2 months, followed by isoniazid and rifampicin for subsequent 4 months, the regimen that is well known to everyone. It applies also to most of the patients suffering from TB. Both adults and children are eligible to receive this regimen. It can be used during pregnancy, and in certain situations in children, ethambutol may be omitted from the course. The new 4-month regimen for patients 12 years and older consists of isoniazid, rifampicin, moxifloxacin, and pyrazinamide for 2 months, followed by isoniazid, rifampicin, moxifloxacin for another 2 months. This regimen was recommended after review of the evidence from major multi-country clinical trials, so-called Study 31. There are several limitations for the use of this regimen in age, weight, and also in type of TB. It is also not yet recommended to be used during pregnancy. The composition of the regimen is standard, and doses of at least 2 medicines, the rifampicin and rifampicin and moxifloxacin, are fixed, as well as the regimen duration. It is also recommended to be given the 7 days a week, so every day. Another new regimen that is recommended is the regimen that consists of the same medicines as the 6-month regimen, isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by for 2 months, followed by 2 months of isoniazid and rifampicin. This regimen can be used in children fulfilling the criteria of age between 3 months and 16 years, so children and adolescents, and the definition of non-severe TB as reflected on this slide. In this regimen, ethambutol, again, in the similar situations as the 6-month, can also be omitted. This table that I put on this slide, and it's also included along with other implementation guidance in the operational handbook, can help in the selection of the appropriate regimen based on age, but also needs to take into account the disease severity, patient or family preference, and access and cost of the regimen and its component medicines. The operational handbook on drug-susceptible TB treatment also provides the updated TB treatment outcome definitions applicable for treatment of both drug-susceptible and drug-resistant TB, and also valid for regimens shorter than 6 months. In the operational handbook, we also included the web annexes with reports on the recent systematic reviews on dosing of first-line medicines. These annexes include detailed reports of the reviews, one focusing on adults and another one on children, and present the overall conclusion that doses of first-line medicines currently recommended remain valid. There is some research that is happening in this area, but until we have the new evidence, I think it is an important finding. Now, moving to the treatment of drug-resistant TB. In May this year, WHO announced upcoming changes in the treatment guidelines of drug-resistant TB using rapid communication as a vehicle for that. Several changes have been communicated. So the first one relates to the 6-month BPAL-M regimen that consists of bedaquiline, pretomaniat, linezolid, and moxifloxacin. That regimen that can be used programmatically now in place of the either 9-month or longer 18-month plus regimens in patients above 14 years with obviously MDR TB, but also patients with resistance to fluoroquinolones, in which case the regimen can be used without moxifloxacin. It is strongly recommended to do the drug susceptibility testing to quinolones to be sure about this, either before or at the beginning of this regimen. Another change that was communicated via rapid communication was that the 9-month all oral bedaquiline containing regimens are preferred over the longer 18-month regimens in both adults and children with MDR or rifampicin-resistant TB. There are certain limitations related to the previous exposure to the second-line treatment, including bedaquiline, the quinolone resistance, and the severity of the TB disease, being the extensive pulmonary TB disease or severe extrapulmonary TB. The main difference from what was recommended previously, that the 2 months of linezolid can be used as an alternative for the 4-month ethionamide in these regimens. Finally, the patients with extensive forms of drug-resistant TB, like XDR TB, according to the new definition, or those who are not eligible or failed the shorter regimens, will benefit from individualized longer regimen. Again, designed in the same way that was recommended, is recommended in the current WHO guidelines. The updated guidelines basically present a new approach to regimen selection, prioritizing shorter regimens over longer regimens, starting from BPAL-M to 9-month, and the longer regimen used as a last resort option. The updated guidelines on drug-resistant TB treatment and the handbook are planned to be released by the end of this year, most probably this December, and will include detailed recommendations as shown in this slide in several sections. The sections in red are basically new chapters of the guidelines. The rest is the consolidation of the previously already printed and released chapters. Last but not the least, I want to also touch base on the tuberculosis care and support, for which in July this year, WHO also released the updated Tbkan support guidelines and the new handbook. While guidelines include recommendations for care and support interventions for all people with TB and models of care for people with drug-resistant TB, children and adolescents. The handbook, the operational handbook, is the new document that adds some operational guidance on people-centered care and support interventions to enable TB treatment adherence, health education and counseling, models of care for TB services, and a chapter on palliative care for TB patients. So in summary, there are several new treatment guidelines and handbooks that have been released or will be released this year. New and shorter regimens for both drug-susceptible TB and drug-resistant TB are now recommended. It is noteworthy to say that for the first time, the duration of all TB treatment, be it drug-susceptible TB or drug-resistant TB, can be of the same duration. And all of that shows a significant reduction of the duration of TB treatment. So with this, I also want to mention what my colleagues have mentioned earlier, that with the release of the WHO knowledge sharing platform in June 21, the guidelines and handbooks, including the ones on treatment, are also accessible through this microsite via desktop, laptop, tablet, or smartphone, as Dennis has presented. The QR codes for the links are on this slide. So finally, to conclude, I would like to acknowledge my colleagues in the treatment team here in WHO TB program, and other colleagues that in our department, also those who participate in this postgraduate course. And thank you all for your kind attention.
Thank you very much, Fuad, for the very informative and concise, but very informative presentation. I think you went through lots of material in really a short time, and it's exciting. There are really important changes coming up and new opportunities for treatment of both drug-susceptible and drug-resistant TB. There are already a few questions in the chat, and we do have time to answer them. Maybe I can, I don't know if you can see them, otherwise I read them up loudly. The first question is about whether there is a place for the 9-month regimen now that we have a 6-month regimen, BPAL-M, that will be used. Is only for settings where predominant is not available, or is there another?
Well, yeah, thank you. I'm just now seeing the chat since I stopped sharing. Thank you, Matteo, for reading that loud. There are certain limitations in these different recommendations that we should consider. Just to give you an example, of course, the availability of the medicines will be definitely a limitation, but there are also limitations embedded by the limited amount of the evidence that we had. For example, with BPAL-M regimen, the whole evidence was really limited with the age group above 14 years old. That's why we are obliged to keep that limitation and only recommend that for above 14 years. Therefore, for children and perhaps also for during the pregnancy, since BPAL-M has also that limitation because it contains the new medicine pretomanid that has very, very limited data and some signals on in animals on some reproductive toxicity. The option becomes the 9-month regimen, basically, in as a first option in those groups. So that's something that we should consider and use that flexibilities and around these different limitations to prescribe the best regimen. So there is a question about BPAL-M, whether it should be prescribed in the absence of DST to quinolones or with confirmed susceptibility for above 14 years. So with BPAL-M, of course, it is ideal that the DST, and since there is a rapid DST for fluoroquinolones that is now available, is done. But in the situation where it is either not possible or not possible to have the result, if patient is eligible by other criteria, the best probably option is to start the regimen, have the result, and if there is a resistance to quinolones, if there is a possibility to drop moxifloxacin and continue the treatment with BPAL, bedaquiline pretamine linezolid combination, it was also showing a very good efficacy. And the dropping moxifloxacin is simply when it is confirmed that not to add any additional toxicity to the regimen unnecessarily. So yes, it is. The other question that I see about the twice or thrice weekly dosing that is not recommended for TB treatment. Yes, it is true. Oh, thank you. It's Lynn who provided that answer. Any data suggesting delamanid that has similar efficacy to pretamine? These are medicines from the same group, but the head-to-head comparison, we just don't have that data available. So that's why we cannot just recommend or comment anything on the possibility of replacing one medicine with another. So another question that I see, that whether some countries continue to use BPAL and not BPAL-M even for confirmed quinolone susceptibility. Well, my view is that it's depriving patients from the effective drug. I think the having quinolones there strengthens the regimen, increases the probability of success, because the patient is not a standard category. There are patients with different disease severity, and it's really important to consider all factors. If there is a confirmed quinolone susceptibility, or if it is unknown, I think it is better definitely to use BPAL-M rather than BPAL. Okay, I'm just scrolling down. Whether BPAL-M can be used for patients with extensive disease or severe forms. Since in the available evidence, which is not abundant, I should say, again, it's fairly small numbers, and we had just 2 fairly small trials, that the TB Practical and Zinix, and some data from the NIC study from before. But all of them included patients, didn't exclude patients with extensive disease, severe forms, or patients with HIV. Therefore, there are no limitations that are being put forward for the BPAL-M regimen in that regard. But I think, further research and studies and operational research and programmatic implementation with this regimen will help to refine this further. Okay, see many questions.
Don't feel obliged to answer.
Right, I see. Thank you for my colleagues who are trying to address some of them in the chat. I'm just kind of struggling to see which were already answered and which were not.
I can help you, because it's a lot. There is one question about the side effects of linezolid, and the fact that it is basically a drug that is giving important side effects in the 9-month regimen, and what to do for BPAL basically, and how we are going to manage that.
Well, I think the part of this review and assessment that we had during this year, during the guideline development, was a careful review of the Zinix trial and the data within the BPAL regimens and to identify the dose that cause the minimum of the adverse events without any major change in the efficacy. And that's why the BPAL-M and BPAL regimens are recommended with the 600 milligram per day dose, which should minimize, will not eliminate, I imagine, completely, but will that's kind of seems to be the most optimal dose of linezolid to avoid most of the adverse events. When it comes to, I'm not sure if it was also mentioned in the context of the 9-month regimen, there is a possibility of replacing ethionamide now, 4 months of ethionamide with 2 months of linezolid. That probably would not be causing many adverse events because, first of all, it's actually the on-label use of linezolid, and it seems that from the available evidence, most of the adverse events of linezolid start to occur after 2 months, except of the some that may also start happen fairly early, but they are quite rare. What is the place of the 9 months all oral beta-carotene containing regimen? I think it still has a place because the BPAL-M has limitations. So basically, whenever the BPAL-M, the patient is not eligible for BPAL-M, the next in line option is the 9-month regimen. And just an example, of course, we will put more details in the guideline and the operational handbook document, but children adolescents below 14 years of age would be directly beneficiaries of the 9-month regimen.
Okay.
Okay. Yeah, I think we tried a lot, and I think we'll continue in the chat.
Yes, actually, we have time. We have 30 minutes for a discussion afterwards. So I took notes of some of the questions that were not fully answered, although you did a great job, Fuad, in going through it. Some of them were actually quite tough questions. So thank you very much, Fuad, and also to all colleagues that are helping with the chat. I hand over now to Norbert for introduction of the last presentations today.
Yeah, thank you so much, Matteo. Thank you, Fuad, for a wonderful presentation. We really learned a lot. So our next presenters are Dr. Kerry Vani, who's a team lead in the Vulnerable Populations Community and Co-Morbidities Unit under the Global TB Program. She leads the team responsible for the Global TB Program's work on vulnerable populations, TB and HIV, and comorbidities. She has a background in public health and holds a PhD from Australian National University. The other presenter is Annabelle Bedley, who's a technical officer working within the same vulnerable populations community of comorbidity unit since the year 2010. The work focuses primarily on the development of normative guidance on TB, HIV, and comorbidities, global monitoring and evaluation of joint burden, and of TB HIV collaborative activities and supporting countries to scale up policies on integration of TB HIV services. So she holds the MSc in Public Health from the London School of Hygiene and Tropical Medicine. The presentation will be around the current recommendation on TB management in children and adolescents, and a new framework for collaborative action on TB and comorbidities. Over to you, colleagues.
Thank you very much, Norbert, and I hope that everyone can hear me well and can see the slides. Clear. Very good. Yeah. Okay, great. Thank you very much. So good morning, good afternoon, and good evening, everyone. It's a real pleasure to be part of this postgraduate course at the Union Conference on this topic. And as Norbert mentioned, we're going to be talking about the current WHO recommendations on the management of TB in children and adolescents that were published by WHO this year. as well as a new framework for collaborative action on TB and comorbidities, which was actually published yesterday, which Annabelle Badley will talk about. So before we go into the presentation, I'd like to acknowledge my colleagues and everyone involved in the development of these products. And we are going to have a quick poll before we start. We have no conflicts of interest to report. And if we could launch the poll, that would be great, Caroline. Thank you. Hopefully I'll be able to see it as well. Great. So the first question is about the management of TB in children and adolescents, and which of the following recommendations that you will be implementing or planning to implement in your country or your context. So if you could start responding to that poll, that would be great. Then there's a second question, which is about what are the key enablers to providing people-centered care for TB and comorbidities. And this is a free text response. So if you can also type in for that second question, we'd really appreciate it. I'll just wait a few minutes. I think keep going. Good. Just keep going for a bit longer, I think, if you can keep responding to those two questions. And then we're going to talk about these two topics. Great. Up to 60 responses. Just give you another minute or two. So bedaquilin's popular decentralization, the short intensive regimen for TB meningitis, expert testing using stool. Okay, we might get to 100, then we'll stop. We've got 93. Six. Okay, great. All right, Caroline, could you display the results? Great, so just looking at the first part of the poll, on which of the following recommendations are you implementing or planning to implement? We have 48% for stool, 36% for the decision algorithms, the same for the 4-month regimen, 17% for the short intensive regimen for TB meningitis, bedaquiline 35%, delaminid 20%, and decentralization and integrated care. And I don't think we can see the responses for question 2, but that's okay. We'll come back to that. So thank you very much for doing the poll. I'm going to start, as mentioned, by talking about the recommendations on the management of TB in children and adolescents. So firstly, I'd like to say that WHO held a guideline development group meeting in May, June of 2021. The GDG reviewed evidence on a wide range of PICO questions, which covered diagnostic approaches, the treatment of drug-susceptible TB, treatment of TB meningitis, as well as the treatment of drug-resistant TB, and finally, models of care. So these are the questions that you can see in yellow on the slide. A rapid communication followed, and this was published in August 2021. So this is the blue and white document that you can see on the top right of the slide. And then in March this year, on the occasion of World TB Day, consolidated guidelines, as well as an operational handbook, were released at a UN press conference. And these updated guidelines replaced the 2014 second edition of the Guidance for National TB Programs on the Management of TB in Children. And you can see the web links for the guidelines in the handbook there. Now, the target audience for both of these documents includes national programs on TB, HIV, primary healthcare, maternal and child health, as well as health workers at various levels, the education sector, and various organisations involved in TB care and TB programming. The objective of both documents is to contribute to reductions in TB-related morbidity and mortality in children and adolescents, in line with the global targets in the WHO NTB strategy, the UN General Assembly high-level meeting on the fight against TB, and of course, the Sustainable Development Goals. Now you can see this analytic pathway here, which is the analytic framework that was used in the guidelines and the handbook, and it represents the cascade of care. So it's the pathway of TB infection and disease in an individual child or adolescent, and the interface with or retention across various sequential stages of care, or the cascade of care. You can see in yellow on the cascade of care a description of the PICO questions that were asked during the guideline development group process, and I'll talk a little bit about the result of that process in the next few slides. So as a result of the guideline development group meeting, there were 8 new recommendations made that relate to the management of TB in children and adolescents. And then the next 2 slides, I'm just going to go very briefly through these 8 new recommendations. Now, the first one that you can see here is about diagnosis. So it's about in children with signs and symptoms of pulmonary TB, expert ultra should be used as the initial diagnostic test for TB and the detection of rifampicin resistance on sputum, nasopharyngeal aspirate, gastric aspirate or stool, rather than smear microscopy, culture and DST. And the new part of this recommendation is gastric aspirate and stool. Then the next new recommendation is in children with presumptive pulmonary TB attending healthcare facilities. Integrated treatment decision algorithms may be used to diagnose pulmonary TB. And these decision algorithms are defined in the guidelines in the handbook, but they are basically a flowchart that allocates evidence-based scores to the microbiological, the clinical and radiological features that allow a clinician to make a decision to start a child on TB treatment. Then the next new recommendation, which Fuad just highlighted in his presentation, is for a shorter regimen for children with presumed drug-susceptible TB from the SHINE trial. So this recommendation that Fuad went over is that in children and adolescents between 3 months and 16 years of age with non-severe TB, without any suspicion or evidence of drug-resistant TB, a 4-month treatment regimen may be used, and that uses the standard drugs and the standard doses as the 6-month regimen. Now, non-severe TB is defined in both the guidelines and the handbook, and it is defined as peripheral lymph node TB or intrathoracic lymph node TB without airway obstruction, uncomplicated TB pleural effusion, or paucibacillary non-cavitary disease confined to one lobe of the lungs. Then the 4th new recommendation is a shorter regimen to treat TB meningitis in children and adolescents. So this recommendation is for children and adolescents with bacteriologically confirmed or clinically diagnosed TB meningitis, again, without any suspicion or evidence of multi-drug resistant TB. A 6-month intensive regimen may be used, and that's composed of isoniazid, rifampicin, pyrazinamide, and ethionamide instead of ethambutol, And that's an alternative option to the currently recommended 12-month regimen. And the intensive component refers to the fact that all 4 medicines are used throughout the 6 months. Then the next of the 8 new recommendations, 2 of them pertain to drug-resistant TB or multi-drug-resistant TB. And the first of those is that in children with MDR TB aged below 6 years of age, and all oral treatment regimen containing bedaquiline may be used. And then the second of those MDR recommendations is that in children with MDR aged below 3 years of age, delaminid may be used as part of longer regimens. Now, these 2 new recommendations complement existing recommendations on both bedaquiline and delaminid, and effectively they mean that the age limits are removed for both medicines. Then finally, there are 2 new recommendations on models of care. So the first of these is in TB high burden settings, decentralized models of care may be used to deliver TB services to children and adolescents with signs and symptoms of TB and or those exposed to TB. And the second new model of care recommendation is about family-centred and integrated models of care to deliver TB services, which may be used in children and adolescents with signs and symptoms of TB and or those exposed to TB, in addition to the standard models of care. Sorry, my slides keep jumping. So there's two new models of care recommendations. Now, just to go through very briefly the structure of the guidelines and the operational handbook. So this is, they're both structured in the same way using these chapters. So chapter 1 is an introduction. Chapter 2 is about TB screening and contact investigation. Chapter 3 is about prevention. Chapter 4 is about TB diagnostic approaches. Chapter 5 about treatment of drug-susceptible, drug-resistant TB, as well as extrapulmonary TB. And Chapter 6 is about models of care and includes those new recommendations that I just spoke about. Chapter 7 is about special situations. So this includes some additional information such as children living with HIV, children with severe acute malnutrition, palliative care. And then finally, there are a number of annexes which are included in the operational handbook, and I'll walk through a few of those in just a moment. So the consolidated guidelines that I've just spoken about do bring together valid recommendations from other guidelines. And this slide really provides an overview of the different WHO guideline documents from which the relevant recommendations were sourced. So it includes TB prevention and screening guidelines, the BCG position paper, the guidelines on rapid diagnostic tests, as well as drug-resistant and drug-susceptible TB, TB infection prevention and control, as well as some validated recommendations from the 2014 guidelines. All guidelines and recommendations, along with the operational handbooks, are, of course, on the TB knowledge sharing platform that Dennis spoke about earlier, as well as FUED. And we're also in the process of developing 2 e-courses on the management of TB in children and adolescents, both of which will also be available on the WHO TB knowledge sharing platform, as well as the Open WHO platform. Now, just a few words to conclude about the operational handbook. So the content of the operational handbook is based on some of the existing WHO operational handbooks, such as TB screening, contact investigation, etc. But in addition, there is some newly developed content for topics that weren't covered previously in other operational handbooks. In the operational handbook, there is some color coding used for boxes, so you can easily recognize what the purpose of the box is. So for example, there are green boxes with the WHO recommendations, orange boxes with specific information, examples and resources, and there are blue boxes with some of the key points and key messages, which usually comes at the end of each chapter in the operational handbook. And finally, I'd just like to say in the operational handbook as well, there are a number of annexes that I spoke about earlier. So these contain some practical information for TB programs. So they include information on tuberculin skin testing, for example, sample collection methods, standard operating procedures for sample collection methods, as well as a new dosing table for the second line medicines, where we have dosing recommendations right down to 3 kilograms, so right down to birth. So I will finish here. Just want to thank you for your time, and I'll hand over to Annabelle, who will speak about the framework for collaborative action on TB and comorbidities. Thanks, Annabelle.
Thanks very much, Carrie. Can everybody hear me?
Yeah.
Good. Okay. So good morning, good afternoon, and good evening, wherever you are. So I'm going to, as everybody said, I'm going to be providing an overview of the framework for collaborative action that actually came out yesterday. And I have no conflict of interest either to report. So the 5 main health-related risk factors and drivers of TB are alcohol use disorders, diabetes, HIV infection, smoking, and undernutrition. And these 5 risk factors accounted collectively for 45% of new TB episodes in 2020. And their contribution is published each year in the Global TB Report. So the next one will also include them. In addition to these 5 main risk factors, and something that's often left off the agenda, mental health disorders, as well as substance use which increase the risk of treatment delays, multi-drug resistance, as well as poor outcomes, such as loss to follow-up and even death. So collaborative TB HIV activities and management of comorbidities sits firmly within Pillar 1, as you can see here, component C. But of course, it draws very much on the other two pillars, bold policies and supportive systems, as well as Pillar 3 on intensified research and innovation, without which it would collaborative action on TB and comorbidities would not be possible. Next slide, please. At the respective UN high-level meetings on TB, NCDs, HIV, and UHC, member states all committed to providing integrated care, and specifically at the 2018 UN high-level meeting on TB, they committed to strengthening integrated care for all these health-related risks, risk factors and comorbidities. And within the context of UHC. Next slide. A review of policies and national strategic plans in high TB burden countries found that despite the existence of all the WHO guidelines on all these conditions, some of them may not be specifically TB and the comorbidity. So for instance, the GAP intervention guide is actually for use of management and screening of mental health disorders, and that is more for use in primary care settings, so could also be used amongst TB patients. But anyway, despite the existence of all these, the review of the policies found that in fact, there was very limited uptake by countries, or it varied considerably, and also there was very much where policies had been taken up. There was a mismatch between guidelines and what was committed to in the national strategic plans for TB, as well as a mismatch between what was in the national strategic plans for TB and for the other disease areas, for instance, a national strategic plans for and non-communicable diseases. Anyway, to address this gap, WHO has developed a framework for collaborative action on TB and comorbidities. And the process of development is really based on sort of triangulation of data from literature review of evidence on barriers and enablers, as well as existing WHO guidance on integration and primary care. And interviews with survivors of TB and comorbidities, as well as focus group discussions with health programs to gain program and clinical perspectives. And the framework was also reviewed during a stakeholder consultation and reviewed by expert peer reviewers. And drawing on the WHO policy on collaborative TB HIV activities, which I'm sure most people will be well aware of, the framework focuses primarily on the objective of establishing and strengthening collaboration between the programs and also sectors to ensure delivery of integrated people-centered services. So it comprises 5 key action domains for scaling up people-centered care for TB and comorbidities. And these are strengthening governance and accountability for collaborative action, conducting an analysis of access to quality services for TB and comorbidities, coordinating planning and resource mobilization for collaborative action, implementing and scaling up people-centered services for TB and comorbidities, and finally strengthening and monitoring and innovation and research. So to ensure governance and accountability, there are a number of actions that include the following: strengthening or setting up platforms for coordination at all levels to include relevant stakeholders, including civil society, affected populations, to strengthen coordination, accountability, and political commitment. Ensuring financing and legislation promote people-centered care. I mean, for example, financing models for providing comprehensive services, and legislation to permit qualified providers to prescribe treatment for both TB and comorbidities, that sort of thing. And engaging and empowering civil society and affected communities at all stages for planning, from planning to monitoring and evaluation, as well as advocacy. Next slide. So to guide planning, priority setting and implementation, it's essential to understand the joint burden in terms of morbidity and mortality due to TB and comorbidities, and as well as the accessibility of care relevant for the different comorbidities and the socioeconomic impact of the comorbidities on the patient. And this means assessing the burden, understanding the access to the different services, the financial burden in terms of patient perspective, and mapping the health service delivery and identifying the gaps, as well as understanding why the gaps are there. So drawing from the people-centered framework, essentially. The framework's got a number of case studies, and this is just one from Georgia, where integrated screening and care for TB, HIV, and viral hepatitis in primary care settings was first piloted and then scaled up nationally. And the key elements to allow introduction and scale up included partner coordination through a steering committee to set up and lead implementation with memoranda of understanding, defined roles and responsibilities, piloting in an area where the joint burden was identified to be elevated, local public partnerships, public-private partnerships, strong political commitment and funding by the local government, and monitoring and evaluation framework with targets. So before planning and resource mobilization, countries really need to prioritize the identified key comorbidities and risk factors based on the situational analysis, which had been done earlier in the prior action domain, in close collaboration. And the prioritization really needs to be done in close collaboration with the key stakeholders. Programs should then work together to define and orient models of care that assure the provision of integrated services, preferably at the same time and location, and as close as possible to the people who need them. And to ensure sustainability, planning should be harmonized between the programs and also within the country's national health strategic plans and health system strengthening agenda, and overall efforts to achieving universal health coverage, taking into account all the health system building blocks. Programs should work together to seek allies and develop joint advocacy strategies and align communication to garner buy-in for and promote collaborative action. So the following actions will support implementation and scale up. Next slide, please. For integrated services. Joint development and alignment of policies, guidelines and procedures, mobilization of qualified multidisciplinary workforce, ensuring access to essential medicines and equipment and products for TB and respective comorbidities, civil society for refinement of services, and access to social protection to prevent increased financial burden, have more than one disease. Also, uptake of digital technologies and phased introduction and targeted scale up focused on geography and health systems opportunities, for instance, placement of existing services. So the next case study we have is from Mexico. And this is where 36% of people with TB had diabetes in 2020, or people who were tested for diabetes had diabetes in 2020, if you see what I mean. And diabetes in the general population is also rising rapidly. So this is a real driver for TB in Mexico. Bidirectional screening for TB and diabetes was first introduced in 2012. And the way they did it was they selected priority facilities based on the joint burden of TB and diabetes, as well as the infrastructure and willingness by the relevant authorities to participate. And then they developed guidelines on TB and diabetes that were incorporated into the national TB guidelines and training curricula. And they conducted regular meetings, which were held to sort of foster collaboration. And then joint indicators were developed to capture the joint burden and drive progress of collaboration. So finally, we have monitoring and evaluation and operational research, which are critical enablers for scaling up collaborative action on TB and comorbidities. And to support joint M&E and operational research, it's really vital to adopt indicators and set targets for the collaborative action, and strengthen TB and comorbidity surveillance, including through alignment and interoperability of recording and reporting systems, as well as digitalization using platforms such as DHIS2. And as part of scale up, recording and reporting tools should be updated to capture data, and human resource capacity need to be developed to collect and analyze the data, and data reconciliation and cross-checking needs to be conducted on a regular basis. So to conclude, my final slide, just to, so meeting the NTB strategy targets will be impossible without addressing TB, comorbidities and health-related risk factors. And the response to TB and comorbidities can be strengthened, drawing on the TB HIV experience. And collaborative action really relies on strong governance and accountability, understanding the joint burden, coordinated planning and resource mobilization, and scale up of people-centered services, taking into account the health system building blocks, as well as a good, strong monitoring and evaluation and operational research. Thanks very much.
Yeah, thanks a lot for an excellent presentation. We're going to move to our Q&A session. I'll ask Dr. Matteo Zignol to take us through. I hope you already put your questions on the chat, and our colleagues Kerry and Lynn will be helping to monitor the chat. Over to you, Matteo.
Thank you very much, Norbert. There are a couple of questions to begin on the presentation that we just heard from Kerry and on Annabelle. Great presentations on the new evidence on the treatment and diagnosis, treatment management of TB in children and adolescents, and also on this new framework on TB and comorbidities. So maybe one question I would say to Kerry, if possible, is about whether in the operational handbook you describe the greatest barriers for the introduction of new regimens for treatment of TB in children, and also if you could discuss about any new diagnostic options that you have included in the guidelines and the handbook.
Yeah, sure. Yes. Okay. Thanks, Matteo. Yeah, I think in terms of new diagnostic options, probably stool is the most probably interesting option, I think, especially for young children. So stool can now be tested with both Expert and Expert Ultra. There is a stool processing guide that was also released by WHO, and I can put the link into the chat after this question. So I think, yeah, of course, there's now the full range of specimens, so nasopharyngeal aspirate, gastric aspirate, sputum and stool for pulmonary TB, as well as the full range of extrapulmonary specimens. But I think stool is probably the newest and potentially the most exciting, especially for children and for younger children. And in terms of, Matteo, you asked another question about barriers for regimens.
Right, you had an important meeting in Zambia recently, and I wonder whether you already some feedback from countries about, and I was really glad to see that many people in the pool have stated that they are planning or they are already starting using the new regimens shorter for children, which is great. So if you could elaborate a bit on that.
Yeah, sure. No, thank you very much. So we recently, just to inform people on this postgraduate course, we recently had a regional consultation on ending TB in children and adolescents for the African region in Zambia, and we've been involved in a lot of other dissemination activities in other regions as well. So there has been, of course, a lot of discussion about the shorter regimen for drug-susceptible TB coming out of the SHINE trial that Fuad and I both spoke about, as well as the shorter TB meningitis regimen, which is a 6-month regimen instead of a 12-month regimen. Now, for the shorter regimen to treat drug-susceptible TB, it is only for children in a certain age range, so 3 months to 16 years with non-severe TB. And part of that definition of non-severe TB does rely on access to chest radiography. So certainly there's been a lot of discussion about, trying to determine among clinicians which children have non-severe TB versus severe, and making that decision between a 4-month and a 6-month regimen. So I think that's been quite a topic of discussion, particularly for that regimen. And I think there's generally been a positive, people have positively reviewed this 6-month regimen for TB meningitis. It does use ethionamide, so countries need to be able to access ethionamide. It has been used in South Africa for many years, but that's also been, I think, quite well received. So we look forward to seeing those recommendations sort of taken up by countries, included in, their national TB strategic plans and rolled out. So. Thanks.
Thank you so much, Carrie. I invite for the very clear answers. Everyone to type your questions in the chat. I think it's very important that we take advantage of the experts in the room here to get like a very prompt and clear answers to any concern or any questions. I have maybe one question on the check the people have hands raised. Otherwise, one question on the framework for collaborative action on TB and comorbidities that was introduced by Annabelle. This is a very new document. As Annabelle said, it was launched only yesterday. Anything that you can say on next steps from WHO, Annabelle, on comorbidities, and if what's coming up, basically.
Yeah.
Thank you, Annabelle.
Sure. So obviously the framework for collaborative action focuses on the first objective of collaboration between the programs. And we are now we're currently updating the TB HIV recommendations, because there have been a number of new recommendations since 2012. We are developing an operational handbook, which will be really focusing on the big gaps and sticking points in the TB HIV response in terms of, so there are gap in case detection, as well as, there are sort of reduced, there's less integration in some areas, and that sort of focus, and also learning from countries in terms of how they've been doing scale up of TB preventive treatment amongst people with HIV. There have been countries that have been doing super boosting their TPT surges, let's say. We are also looking at we are developing an operational handbook on TB and diabetes. There have been a number of recommendations, as we mentioned in the chat. You might have seen we have got a negative recommendation for systematic TB preventive treatment amongst people with diabetes. But certainly there's screening for people with diabetes, TB screening in high burden settings, and also there's a number of guidance from the NCDs in terms of thresholds for diabetes and diabetes testing, as well as treatment options. So that will be in the operational handbook for diabetes, and we will also be looking into the guidance for TB and undernutrition, because that was last developed in 2013. So we've got quite a few guidances and operational handbooks on the agenda. So just watch out and watch the space, and we'll share with you hopefully at the next meeting.
Thank you so much, Annabelle. This is a really great development and very much needed, as you say. And there is lots of new evidence and new developments, and also really the need to update the current guidance. I now have actually 20 minutes for a general discussion, and what we are going to do with Norbert is we're going to pick up and read loud the questions that have not been answered. So it's very difficult for us to go back to the chat and find out which questions were not answered. I have already a few of them noted here. I will start with those. But if you feel your question was not answered, I will very much appreciate if you could retype it in the chat so that it comes up in the chat. So I'm reading now. Yeah, I think there was a question for on the 6-month regimen for meningitis and more sequelae. I saw that there is already an answer from Carrie, but Carrie, do you want to say a few words about that, please, if you can?
Yeah, sure, Matteo. Thank you. So for the 6-month regimen for TB meningitis, when it was compared to the 12-month regimen, certainly there was a lot lower rate of mortality. So children were more likely to survive, but that does explain why there was actually a higher proportion who had sequelae. So the fact that there was a higher proportion with sequelae was related to the fact that they didn't die, they actually survived. The sequelae were mostly mild. You can see the data in the guidelines under the evidence section, but there was certainly a lot higher rate of survival. So I hope that answers the question.
Thank you so much, Kelly. A very, very clear answer. Yes, there was a question on TB vaccines. I can say a few words about that, but let me first give the floor. I noted that question to the colleagues to answer other an open question. Yes, there is a question on the specificity of the C protein reactive test in the diagnosis of TB in people living with HIV. I don't know if Vinit or sorry, Cecily. If Sabinash or Cecily want to answer.
Yes, I can just say, I think it's best to go directly to the guidelines to see this, because there are many different values. It depends on if you're looking across all people living with HIV or people on ART or not on ART or inpatients. And it also depends on if you're using a cutoff of 5 milligrams or 10 milligrams. Annabelle did provide in the chat earlier one specific value that would probably be of interest. And of course, now I can't remember. It was when it was used in sequence with
Cecily, I put it in the chat now.
Again, okay. So when here we go. When used in sequence with the 4 symptom screen, it's got a specificity of 64%. But again, I do recommend you look at the guidelines and see the full range of values there.
Thank you.
That's this is for people who are initiating ART care, so they're not yet on ART.
Okay, yeah. So this is for people living with HIV newly enrolling on ART care or re-enrolling in care.
Thank you very much, Cecily and Annabelle. It's a very clear answer. There is a question, I think, for Avinash on TPT regimen for pre-XDR and XDR contacts. Very difficult question for Avinash. I don't know if
probably an easy answer. We don't have a recommendation right now.
Yes, exactly. Any plans, Avinash?
So apart from the 3 trials I mentioned that are happening among contacts of drug-resistant TB patients, we are not aware of any more trials amongst contacts of pre-XDR or XDR patients as of now. So unlikely in coming year or 2 we will have any different recommendation.
Thank you, Avinash. And as you rightly presented, 2 of these 3 trials are using quinolones, right? Levofloxacin. And one of them is using the Lamanid, the 3rd one. So we'll have to see what comes out of the trial. Excellent. Thank you, Avinash. I think there was a question. Yes, a new question. Any updates on different testing specimen for children other than sputum and bronchial lavage or gastric lavage? I don't know who wants to answer the question, whether it is Nazir or
I think, Kerry, I mean, you can, I think you presented on the stool, but maybe you can just re-emphasize.
Yes, go ahead, Kerry. I think you're muted, Kerry, sorry.
Okay, sorry, my apologies. Yeah, the most recent updates are on gastric aspirate and stool using Expert Ultra. So they are the most recent updates that were included in the 2022 consolidated guidelines. So that means that nasopharyngeal aspirate, gastric aspirate, stool, and sputum can be used with both Expert Ultra and Expert. So
thank you.
They're the latest updates.
Thank you very much, Kerry. And next one, I think, is really for Nadir. It's about the LAM, and actually, if you can talk also to the following one. One is on LAM test, and the second one from Anna.
On LAMP.
Yes.
Yeah, sure. Okay, so in terms of the LF LAM, so we do have recommendations on the current Alere LAM. Fujilam was the sort of the 2nd generation of LAM products, but the company has had some challenges and has gone back to the manufacturing and quality assurance programs. So we expect to see data probably late next year or early the following year. So we don't have any new data on Fujilam in terms of addressing the initial lot issues. There are other LF LAM products coming up. So there's like Abbott, who's got a new test, Salus. There's a few companies that have new products. And they're all currently going through trialing. So we expect to get data by 2024 at least and review all the LF LAM technologies. There is a bit of excitement that they might perform better than the others and will actually be a point of care test. And everyone's pushing for the net point of care, but this would be a true point of care. So I see a question also, what's the difference between LAM and LAMP? So the pronunciation is quite tricky. So generally, LAM is the urine test that's done. It's an antigen that's detected in urine and just uses a lateral flow approach. The LAMP is it's called loop amplified. It's a polymerase. It's a PCR, but uses an isothermal reaction, meaning that it can be done in the field with basically a heat block, and that's what the TB LAMP is. A very crude, basic heat block type of PCR, quite robust and cheap. That was actually recommended many, many years ago, and the recommendations still hold. The price is about just under $6, fairly robust and crude, but only detects TB. So the recommendations still exist, and we still include them in the in the recommendations. Yeah, so you can look at the operational handbook and that'll answer the question as well. Yeah.
Great, thank you. Thank you very much, Nazir. Maybe a last question, I don't know if it's about the sensitivity of the test. I suppose they're talking about tests in stool compared to other samples in children. I don't know if Kelly wants to.
Yeah, we can go.
I mean, it's. Are you there, Kelly?
Yes, yes,
Yeah,
I can take that one. Yeah, can you hear me?
Yes, yes, thank you.
Yeah, sure. Yeah, no, thank you for the question. So the sensitivity using expert in stool was about 60%, 61%, as I recall, slightly higher in HIV positive children at 70%, and that's compared to 65% in sputum, 73% in gastric aspirate, and 46% in nasopharyngeal aspirate. So stool is about the same as sputum, and gastric aspirate is a bit higher at 73%. So, and that's included in the operational handbook on page 61. Thanks.
Thank you. Thank you. Thanks again, Carrie. Oh, there is a very long answer from Sabine. I think it will be easier. I don't know, Sabine, or you want to speak up, or if you're available, or. It will take me a bit of time to go through that.
Sure, thank you, Matteo. Yeah, I was just trying to respond to the question by Anna Tukova about the shorter oral bedaquiline-containing regimens, the fact that they have so many drugs in the intensive phase, 7 drugs, and how applicable that is to children. And I was just trying to explain that you know, of course, we looked at the evidence, and the regimens were used as they were used mainly in South Africa under programmatic conditions. So, of course, with the removal of the age limit to the use of bedaquiline, these recommendations will now also apply to children of all ages. So the 2 shorter regimens, the one with ethionomide, the other one with linezolid, replacing ethionomide. And of course, we haven't looked at evidence on the regimens that include only some of the drugs or leave out some of the drugs. And of course, when clinicians are building individualized regimens, both bedaquiline and laminate are important. And in terms of duration for those individualized regimens, if the children have non-severe forms of drug-resistant TB, the duration doesn't need to be 18 months. And in practice, most clinicians will actually treat for 9 to 12 months. And then, of course, we will need to look at data on further shortening treatment for children. And it will be important to generate those data. And really one of the main research gaps for pediatric drug-resistant TB is about what is the optimal regimen for children with regards to the composition of the regimen and also the duration for children who have quinolone resistance, or their source case has quinolone resistance, or without quinolone resistance, children with and without HIV. And of course, the optimal duration would be in line with what we're now recommending for adults, around 6 months. But we don't have data to just, for example, replace protominate with the laminate in a BPAL regimen, for example. So there are some studies going on. There's one study by the Impact Network that is starting up that will generate data on a 6-month regimen for children. So once the evidence is available, it will be reviewed by WHO. Thank you.
Thank you so much, Sabine, for helping us with this important question. I just wanted to go back maybe to the vaccine question now, and maybe I wonder whether Dennis wants to say a few words on, perspective for TB vaccines. If you are.
Yes, hi Anna. So it's a good question. So there are some candidate vaccines that are on the pipeline. I can send the link here. There will be a new version of the pipeline published at the end of this, on the 27th of October with our new report. we hope that there will be a scalable vaccine in a foreseeable future. We cannot really tell when, though.
Yeah, thank you very much, Dennis. And you probably all know that you all probably know that the vaccine candidate that was that completed the phase 2B a few years ago is M72, is a GSK candidate, is still to enter in phase 3. So as Dennis said, unfortunately, it's a long time to go, several years. Okay, I saw a question on, I had two questions, I think. One, I think it was for Fuad again. It was very early on the side effect of linezolid, and it was about, let me read it if I find it. It was about the severe side effects. I don't know if Fuad can...
Yeah, was it about the use of linezolid in the 9-month regimen? There was one, I think we discussed that. I think I tried to cover that it's but linezolid is definitely the medicine with quite potentially serious adverse events happening, and the same time there is some flexibility that has the limits, of course, within the BPAL-M regimen. You know that also in one of the trials, the TB practical that gave provided evidence for this assessment, there was actually the automatic almost decrease of the dose from 600 to 300 milligrams at some point in the treatment. So while to standardize, I think during the guideline development group, the drive was and the suggestion was to try and standardize and make an attempt to provide the 600 milligram as long as possible, given the caveat that it is fairly short regimen, and as long as this dose can be tolerable, it's to continue that for longer. But there are again the flexibilities in terms of decreasing dose, stopping this medicine, restarting that, and possibly also adding some days of treatment to make up for the missed doses. So this will try to provide what we have from this limited evidence that is available in the handbook. But I guess I think everyone should really bear with us, because while for some other regimens there is a lot of implementation experience, the BPAL-M, BPAL regimen, the implementation comes mostly from several fairly small trials and just a little bit of the operational research that is happening now, for which we're really looking forward to have some additional evidence from.
Okay, thank you so much, Fuad, for these words, for the remarks. I think we can say that with this we want to conclude the session. I think we have been able to answer most of the questions, if not all, and I really want to thank from the WHO side everyone who was able to join this postgraduate course. We have more than 220 people still with us after 3 hours, and of course a big thank to the union who was able to host us as almost every year now. This has become a tradition. And a big thank to all the colleagues, experts that have participated to this session. I'm not going to name you all again, but really thank you very much. And a special thanks to Lynn, who is behind the scene, who actually coordinated with the development of this workshop. I wanted to hand over to Norbert for some closing remarks Thank you very much again.
Thank you so much, Matteo. I also thank all the colleagues for staying to the end. This is a very good retention rate here. We started almost 300, we're still above 200. It shows that you're really serious about ending TB with innovative and updated WHO TB recommendations. This afternoon, we had wonderful presentations around TB screening and prevention, something that we really want to do in all our programs, all our countries. We've had a lot of good news regarding TB diagnostics, what is in place, what is coming. We've really had a robust discussion around that. We've heard about TB treatment regimens, shorter regimens for all that are in the pipeline, something that is going to make it possible for the first time to have a treatment duration for drug-resistant TB or rifampicin-resistant tuberculosis, as well as drug-susceptible tuberculosis. So this really has the potential to boost the treatment success rates in our programs. We've looked into this in South Africa, and we see that with our current 9-month regimen, patients get 23 tablets a day for MDR treatment. 23 tablets a day for 9 months is really a lot. And remember, 60% of them at least are living with HIV. Now, if we bring these 6 months regimens, we bring it down, we bring pill burden down from 23 tablets a day on average to 23 tablets a week. So really is recipe for better outcomes, better tolerability, acceptance, and all the benefits in terms of saving money on drugs, buy more drugs for more patients, save on laboratory follow-up and all that. But we also got exciting presentations around efforts in improving TB in children, the use of drugs like bedaquiline, all-age children, and also delaminate will be used, in age younger, in children younger than what we did before. Then all those are very, very exciting news. The framework for collaborative action on TB and comorbidities is very, very exciting. We had what to do with TB and diabetes, nutrition, and all the comorbidities. So on that note, let me one more time thank the speakers and thank everyone for staying online. Our webinar has come to an end. Thank you so much.
Thank you, everybody. Thank you to all the speakers. Thank you to everyone for attending the session. I just want to remind our participants that once the Zoom meeting closes, you will see the survey appear in your browser. We would really appreciate if you can complete the survey in order to provide feedback on the session. Also, you will receive a follow-up email in the next few days with the link to view the recording of today's postgraduate course. And I also want to remind our participants that the session today is accredited by the European Board for Accreditation in Pneumology. So you'll be able to receive some CME credits for your attendance. And on behalf of the union and our presenters, thank you for joining us today and enjoy the rest of your day. Thank you very much.
Thank you. Bye.